Yeah. Good morning, ladies and gentlemen. You've heard various talks today. Some of the things, what we do. Sometimes it's important to say why we do it. You've heard reference in the ankle talk about outcomes. We've heard about ACLs, and registries are becoming much more common. So I thought it's important that you know the background of the Australian National Joint Replacement Registries. We all know that joints relieve pain, restore movement, restore our patients and also our friends and families to function, get back to work. It's actually an investment, although it's often looked at as a cost. I believe it's a great investment in our community. And if we measure outcomes in dailies or qualies, joint replacements come out on the top. And here are a number of hip replacements, femoral components. They all look similar, but they look very different. So how do we actually know which ones work? That's why we need some post-market surveillance, and that's where the registries come about. The Australian National Joint Replacement Registry started in South Australia in 1999, and let me tell you, at that time there was not universal support for this. There were in fact surgeons very worried about what would happen with the data. Nevertheless, the proponents succeeded, and the joint replacement went national in 2002. It now has participation by all public and private hospitals, which is quite amazing, and voluntary participation by all joint replacement surgeons. Patients can opt out, but actually very, very few patients have opted out. To my knowledge, only 13 in 15 years. It is part of the federal quality assurance legislation, so that the data which is collected is actually protected, and so that lawyers do not get access to either surgeon or patient information. So what's the purpose of the registry? Well, it's a place where we can actually collect the demographic data on joint replacement surgery. How many do we do? Who gets them? What is the age? What prostheses go in? What combinations? So a large amount of data is collected, and the registry now has more than 1 million joints in the registry. So this is what's called big data. It also provides a mechanism to look at audit for hospitals and for individual surgeons, so that we can learn and we can improve the outcomes. Revision is, of course, a clear endpoint of failure, and our registry, in fact, only looks at revision procedures, any revision procedure. So even when only part of a joint is replaced again, it's counted as a revision. And the purpose is, of course, to try and reduce the revision rates. We hope that prosthesis will last longer, that outcomes for our patients and for our community actually will improve. There are quite a lot of different reasons why joints will fail, and they're not that difficult to make up. Sometimes it's a failure of the bone, so that patients with a good joint actually go skiing, fall over, and break their femur. The revision of that will be counted as a failure of the whole procedure, but of course that's why we need to differentiate that from loosening, which is a different mechanism, or subsidence. Infection will affect about 0.5% to 1% of our joint replacements, which is a different form of failure. So the prosthesis might be good, but infection loosens it. Recurrent dislocation may be due to surgeons, due to patients, or due to prostheses. You sometimes have fractures of the prostheses themselves. So the neck of those femoral components is the weak spot, and they can break, but we also have problems with different materials. Then, of course, everybody is aware of the metal-on-metal disaster, which we've had here only recently, and that again is a prosthesis-specific issue. Reasons for failure can be related to the design or the manufacture, which is a material issue. It can be related to the surgeon, or the wrong choice for the wrong patient. It can also be related to the patient's own activities. And then, of course, the biology. How does the body cope with big foreign materials and the very small wear particles which are created from moving two surfaces on each other? So currently we have over 1 million joints in the registry, which are mostly hips and knees, but we also have the largest shoulder registry in the world, and we also collect other, such as John Legreen's ankle joints, wrist joints, and spinal prostheses. We look at these with the so-called Kaplan-Meier survivorship curve. So that is a curve which starts at 100% and gradually goes down over the years. Or to turn that around, you can have the cumulative percentage revision rate, which starts at 0 and goes up. And then you can also calculate hazard ratios, which is a way of looking if a particular patient has a particular joint or have an increased chance of having to have a revision at a certain stage, and we add the p-values, which are a way of predicting probability. So here, for instance, you can see the cumulative percentage revision comparing the new and the old polyethylene. So the old polyethylene on the green line has a much higher revision rate. The registry reports the prostheses which have a higher than expected revision rate. If they are 2 or more times higher when compared to all other prostheses, we actually start looking at them and also notify the authorities. Several factors may contribute to that, and the registry is very cautious in identifying prostheses, not only because there are some legal implications in terms of the company, but also because we are very aware that there are patients who have these prostheses in there and who may be unnecessarily alerted by such data. So ultimately, in fact, not the registry, but the Therapeutic Goods Administration is responsible for the licensing and also for the withdrawal of prostheses. The registry has international collaboration, and in fact there is a society of registries where a lot of things are discussed because there are different statistical methods. They compare. If one registry finds there's a problem, we ring up other registries. Are you also seeing problems with that prosthesis? Different prostheses are available in different countries so that we actually have complementary type of information. And we try to add some patient-reported outcomes, which is a very expensive and laborious way of collecting meaningful data. The New Zealanders do it with about 20% of their patients, and our registry is going to start doing that on a very limited 5,000 cohort to see whether we can actually do so and get meaningful reports. So what does the registry do? The registry actually reports a whole lot of specific data, for instance, on hips and knees. There is also a lay summary, and it goes through all the bits and pieces which I've listed there. And the registry report is a publicly available document, so you can actually find it on the net if ever you're interested in certain prostheses or certain reasons why surgeons do what we do. For instance, a few years ago, resurfacing was very popular. Look here, why are we seeing that we almost do no resurfacing in women and only very little resurfacing in men? Because if we look at the cumulative revision rate, which is the dark line, it is of course much worse in women than in men. Equally so, there are some fancy prostheses which have what we call modular necks, where you can actually put a different neck length on the femoral component. But here again, if one looks at big data, it's quite clear that they are not as good as the manufacturers are trying to tell us. And the same applies to the old polyethylene versus new polyethylene. And now you'll hear that most prostheses have cross-linked polyethylene, sometimes also cross-linked with vitamin E, which is a much longer duration for the same size and the same components. Why is it that we do uncemented hips in younger patients, because in fact, if you look at the green line, the cemented hips in the younger patients have a much greater revision rate. So I'm trying to show you various examples of why we do things and why big data is very important, because individual surgeons cannot get enough experience or enough patients to actually show these differences. And sometimes if we identify a prosthesis, here look at the cumulative revision rate of a particular prosthesis, you can clearly see it's off the scale. That prosthesis needs to be removed from our market. So no longer recommended in Australia are the metal-on-metal prostheses. Resurfacing has found a place in a very small number of young active men, if at all. Exchangeable necks are out. The Austin Moore prosthesis, which was very common for elderly patients with fractured neck of femurs, is also not as good as a cemented unipolar or a total hip replacement. And some individual prostheses were so bad they were just removed. Now, in addition to the big data, we also have the surgeon portal. Since 2008, surgeons' names are linked to the procedures on a voluntary basis, and so that allows the registry to give me my own data. So this is very confidential because that is how originally the registry was set up to get surgeons' participation. All cases are shown with a reason for the revision, and additional reports can be given. So here, for instance, is my personal data for hip replacements. I'm on the line of the national average, and that can also be presented in a funnel plot, which will be coming out in the next year. It's not yet available for other surgeons, but because I work with the registry, I asked them to make a funnel plot. So I'm down there. The higher up on the line, the more revision rates. And if one looks at my data for knee replacements, in fact, I look pretty good on there. I'm a low volume surgeon, but my outcomes are good. Now, for each of the revisions which I am notified of, I also get a reason, and I can then go back to those patients or look at my data and see what's going on, and thus change my practice if in fact there's a trend which suggests I ought to do so. Now, from last year, as was mentioned earlier in some other talks, we did 44,000 hip replacements, but 57,000 knee replacements, which is quite amazing. And we also did quite a lot of shoulder replacements. I'm sorry, John, but the ankle replacements obviously didn't hit the radar. The statistics will be changing slowly as the registry gets a bit of extra statistical support. We're now looking at ASA rates, which looks at the health of patients, and we're also starting to add the BMI. In terms of the BMI, hips, it's interesting that 60% were actually normal and pre-obese, but of the knees, they were all a category higher. They were pre-obese and obese, which of course we believe is one of the contributing factors to why they're having a knee replacement in the first place. A significant reduction in the rate of the revision has been achieved by our registry. Now, I'm not saying that all changes are only due to the registry, because surgeons have learned a lot over the years. We have better systems, better antibiotics, better care for patients, but still there's been an enormous reduction in the rate of revisions. And if one looks at the total savings to our community over the last 15 years, it's been calculated to be $600 million. The registry in that period cost $30 million. So for the federal government, this was a fantastic investment because it's a 20 times return. And we are not even counting the savings in pain and sufferings. So the results are achieved through identification of prostheses and prosthesis-related problems. You may not know that in Australia we pay a little more than many other countries for prostheses, and many of the companies are in fact very interested in using us as a testing ground for their new devices. We have more prostheses here than many other countries. In Sweden, they have 7 hip replacements in all. In Australia, we now have more than 140 different types of hip replacements. And so you can see that the registry has to do a lot of work to weed out and change in the use of prostheses, such as different prostheses for different ages. And we try to make an evidence-based decision. So when you next hear about the registry, it's a big project for which you as a tax is actually funded through industry, because on each joint replacement which goes into a patient, a certain percentage goes off to the registry to fund this. And we now, from the registry point of view, trying to get more funding from industry, because this information is extremely valuable and we're able to sell such information to other countries. And so the American FDA come and ask us for data. And so this is an international way of improving evidence-based decision making. I thank you for your attention.